So before we, oh, sorry. Yeah. Okay. Okay. Sorry. Um, I have a quick question. Is it okay if we record this video and then post it on our YouTube after? Okay. Yeah. That's
Yeah,
okay.
absolutely. Yeah,
Okay.
yeah, for
Sounds
sure.
good. Thank you.
Yeah,
So I'm just gonna introduce myself. I'm the co-founder and director of Medical Marvels, and we are so happy to have you here. Yeah, and Ashley Chelsea is our research and resource director, and she's also here as well.
awesome.
So
Nice to see
again,
you.
thank you so much for coming. Yeah, and whenever you're ready, you could just get started.
Sure, yeah, and of course. Thanks for having me and thanks for organizing this. I know it's very important for everyone to, I guess, have some insight. So hopefully whatever I can share, and it's of value to some people. So question though before I start, just want to make sure you guys can see my screen. And
Yes, you
then
can.
perfect. And then also just wanted to make sure that if there is, like I do have some parts in here where I'm going to be asking a couple questions or hoping for some interaction. Is that something where you guys could let me know if someone's putting something in the chat?
Yes, of course, we can do that.
Awesome, great. So yeah, just an introduction. So I'm Gunjan. I am a board certified family physician, also a cosmetic injector. I'm also a faculty member for the family medicine residency program at the University of Toronto. So just a little bit of intro, everything I do discuss today, I don't really have any conflict of interest, but it is based on all my experiences so far. And we're hopefully going to just go over a little bit about why family medicine, what it entails, how do we get here, what are some opportunities, and then hopefully some case studies. So again, so I'm board certified both in the United States and in Canada. Completed family medicine training in the US, but practicing here. I am an adjunct professor, so essentially I work with a lot of second and third year medical students from the University of Toronto, and also family medicine residents from the University of Toronto, where they will come and shadow me for a few days out of their semester for their rotations. And we kind of go over some cases and we see patients together. As a cosmetic injector, I do a lot of injectables and Botox. Love to take pictures, so I think I'm a photographer. And then, of course, please follow me on the Complete MD. So a little bit of snapshot. I think a lot of us know how to get here and what it really entails, but I like to put this up here because it gives us a timeline and also helps us understand where we are. So not sure, are most of the people here today at least, are we pre-med? Are we med school? Are we high school? Do we know anything about that?
I think we're a mix of high school and college students. Yeah, so yeah.
Okay, awesome, perfect. So yeah, so I mean, I think if we look at high school and college, for example, or university, both areas being 4 years, I always like to work backwards. So I have an end goal, but I have to see how to get there. So in high school, for example, I always knew I wanted the science stream in university. So I really catered my 11th and 12th grade into sciences based and a lot of math, right? And then in university, doing the sciences background, first and second year were a lot of the required courses. In third and fourth year, I took a lot of anatomy, physiology, orgochem, and other specifics that I needed to be able to apply for med school. So same thing with med school. We get there, whether you're in Canada or the US or Caribbean or UK, wherever you end up. 3 to 4 years for most people. The first couple of years do tend to be the basic sciences. So we do a lot of the knowledge base, a lot of your histology, physiology, anatomy. And then usually in the last 2 years, again, you're doing the clinical sciences, right? So you're doing rotations in different hospitals, in different settings, outpatient as well, to help you gear and get ready for that residency training. Now here it says 3 to 7 years for residency. Just be mindful for Canada, family medicine is 2 years. In the United States, it's 3 years. So these are some places that I've been just during the training. So I don't have my high school picture here, but I was at Rick Hansen Secondary School in Mississauga, Ontario. For my undergrad, I went to McMaster University on the top left of the screen. The bottom left, you can see it's my medical school. So I went to Saba University, which is in the Caribbean. Fun fact, it is Saba is an island of its own, less than 1,000 people per population, and it has the shortest runway in the world. So that was fun when I was landing there. In terms of my rotations and experiences on the bottom right, I did a lot of my rotations in Manhattan. I also did some in Chicago, which is in the middle at the bottom. And then on the top right is where I did my psych rotation in Baltimore. And that's actually the psychiatric hospital. And in the top middle is my residency, which was in Phoenix, Arizona at St. Joseph's Hospital. So family medicine, I think there's so much to know about it, so much to learn. We probably don't have enough time today, but hopefully I can get you guys to go into it possibly. So why family medicine? So I think it's one of the hardest questions to answer because there is such a huge spectrum of different things that you would be exposed to in family medicine, various illnesses, conditions. There's no, specific demographic because you treat everyone from newborn to elderly, and you see all kinds of patients. I really like it because it's a very integrative approach to patient care. And really, I think what it does is it kind of encompasses all different specialties in one. So you may not know the answer to certain things, and you may not know how to figure out very specific, conditions in neurology, for example, or cardiology. But at least it's that stepping stone to help your patient get the care that they need. I think what's interesting is for me, I think I always wanted to do family or internal, but when I did my third and fourth year of medical school, my first rotation was internal medicine. And so very intimidating because we were put into the hospital setting, coming out of like just a classroom setting to be there as a, doctor, almost a doctor in training, was very intimidating. My first day, I think I messed up a lot, but that's how you learn. And then I went to, I think, surgery, pediatrics, gynecology, uh, then psychiatry, and my last rotation of third year was family medicine. And I think it was then when I really realized I wanted family. And that was because I'd gone through all these other rotations by now to know that I loved a little bit of pediatrics and I loved taking care of women's health and, talking to patients and counseling them and also taking care of acute things or doing minor hands-on procedures of surgery. So I think that's what really helped me and kind of go towards the family medicine field. I think it is a great work life balance because it is such a broad specialty that you can always kind of scope up, scope down to wherever you want to be and however you want to work with it. So there's never really a dull moment. The cosmetic injector. So this was something I was exposed to actually in my second year of residency. I was working, one of my rotations was for the plastic surgeon in Phoenix. And I was just thrown into this mix of people coming for Botox and fillers and microderm and peels. And it was just such a different experience from just the medical side. It was very fun. People were coming in because they wanted to look and feel their best. So I kind of got into it that way. And if we look at trends over the last few years, it's just increasing in terms of awareness that we have and people wanting to try different things. And of course, as a family medicine physician, you can include that in your practice. So I love doing that as well. So what's a typical day? Again, it varies. I would say this question was asked a year and a half ago before COVID. It was very different, and now it's different again. So for me, essentially, I'm an urgent care physician right now. So my shifts vary from 9 to 3 or 2 to 8 or 10 to 4, Monday to Sunday. And so I will see anyone, the first patient could be a counseling patient or prescription refill. And then we go into medical conditions of, new onset dizziness or abdominal pain, chest pain. I have a lot of prenatal care patients who come see me, preventative health management. So that's doing like your colon cancer checks and making sure people have done their pap smears and things like that. We do a lot of immunizations in our clinic. As an urgent care, we do a lot of laceration repairs as well. And then recently, I've started doing a lot of Nexplanon insertions. So that's kind of like an IUD for contraception, but it goes into the arm. So very fun. Patients love it. So again, you can always add to your practice. Right now, I'm seeing about 60 to 70 patients a day. Sounds intimidating, 100%, definitely was. Because so in residency, as a resident, whether you're in family or internal or anywhere else, you'll probably be seeing 10 to 15 patients a day. And that's also in the US, just different payer system. I think I can probably talk a lot about that, but I'll skip it. But here, because mostly in Canada, everything's fee for service, the more you see, the more you make essentially. And most physicians, I would say, in their third, fourth year practice are probably seeing about 50 to 60, if not more patients per their shift. And so once I'm done all my shift work, usually I'll do some on the phone consultations, some admin work, hopefully some CME or continuing medical education, perhaps a couple hours with my family. So bigger picture, the reason I've put all these examinations here are the ones that I've taken to kind of get here. And so being part of the United States medical system and training, I took all my USMLEs for the MCCs or the Medical Council of Canada. Those were all the exams I took. Just little things to note. The USMLEs no longer have the USMLE Step 2 CS, which was the clinical skills examination, which has been formally discontinued as of January this year. And the MCC, there's no longer an MCCEE, but all the other examinations are still there. So the NAC-OSCE and the MCC QE2 are very OSCE based or patient stimulation, standardized patient examination. So a lot of case scenarios. So hopefully at the end of the presentation, we'll be able to go through a couple cases. And then, during your rotations, you'll probably learn a lot about how to do an effective examination or evaluation of the patient. But once you're done your medical school examinations and you get into your first year of residency where you do your step 3 or QE2, at the end of your residency is usually when you're looking to get certified. So on the bottom left side of the screen, you guys will see where it says family medicine, ABSM, and CFPC. So for me, I wanted to be certified and practicing with a license both in Canada and the US. So for the US, the ABFM or American Board of Family Medicine, usually you take the board examination in the third year or April of your third year of residency or the final year. And usually you do that once every 10 years. For the College of Family Physicians of Canada, to get accredited, you usually get a CCFP accreditation. And for that, you can either come with or without examination. So essentially, if you're a Canadian medical student, Canadian residency, you will probably do the Canadian examinations only. So here you'll do the CCFP examination. If you are an American grad like myself, and you want to come to Canada, you could go through the route of CCFP without examination, pertaining that you've completed like your residency at an accredited program, and you hold a board certified licensure in family medicine and licensing in one of the states in the US. So I was licensed in Arizona. And now, of course, I'm licensed and practicing in Ontario. So that's the licensure on the right side when you look at your provincial and state requirements. So a lot of resources. It was really hard for me to pick what is good and what is not. Feel free to take a picture if you guys wanted. There are probably 500 books out there. You'll probably see many of them throughout your careers anyway. But the top third of the screen, you can see that I have the books there, which I have used for both my USMLEs and MCC examination. So very theory-based, but very, very quick knowledge, lots of tips and tricks in there. And in the middle of the screen, you see some of the pocket books. So the Harrison's Internal Medicine on the left, great resource, but very, very expensive. I would say it's bigger than the Toronto Notes, but it has, oops, sorry about that, but it has everything and anything you could need. The ones on the right, I still use those. Those are pocketbooks. They're great for being on the rounds in the hospital as a medical student. I even reference them sometimes when I have some patients that I don't know what to do with. And then the bottom third is essentially the different question banks I use to practice for my licensing examination. But as great as books are, we know there's an app for everything. So these are the high yield apps that I find very helpful, very up to date with everything. Most of them, if not all of them, are found on any app store, so iPhone or Android. These are great resources. Again, I could probably spend hours talking about them. I am happy to spend time individually later if anyone needs to go over any apps that are out there, what they mean, how to use them, and also for any resources that you guys may need as well. I'm happy to help out. I brought this portion in just for a couple slides, and it's really to go over some interview prep and resumes. So resumes and CVs, I think, are the foundation of any job, any interview, any position really that we're going to apply for. And I know most of us have great resumes. I think it's important to obviously have them be up to date all the time. Just a couple of things, if I can mention, if you don't already know, please, please, please make sure you have a legible font. Stick to the Arial or Times New Roman. Stick to the 10 to 12 point. I know many of us may not have a lot of experiences at certain stages in life, but don't go to the 20 pointers. It doesn't help anybody. Use bullet points for all of your experiences. If you can, try have a professional summary, but understandable if we're in high school or if we're just starting university or college, that may not be the case. But as you get, more experienced and you come into med school or even residency, you might have a professional summary which highlights everything for you. The one point I really wanted to make is actually about the professional email address. Please make sure it's professional. I also conduct a lot of interviews for residency students, so medical students looking to get into family medicine residency. And I've seen so many professional or unprofessional emails out there. So please make sure it's a professional email address. Double, triple check everything, and try and just write everything in the same tense. So don't mix pre and post in your skills or your job skill sets and description. Just stick to one. Now, interviews. So no matter which residency or which medical school you guys go to, you will always be asked certain questions that are very, very common in every interview. So tell me about yourself. Very, very common question. This is not meant to be something that's rehearsed. And that's another thing I wanted to say. Don't ever rehearse your material. I think it makes it look unnatural. Just be yourself. As an interviewer, I felt was connected more to individuals or candidates who just came in and talked about, you know, something out of the blue. They didn't really have an agenda. You could see that they were very natural and want to have a discussion rather than a rehearsed set of something. So, and tell me about yourself, which oftentimes they will ask you, I feel like we struggle. And so it's hard to not have something rehearsed, but try and have a few bullet points, try and have a little summary in your head on kind of like how you got to where you are, why are you here today, and how do you think this program or job can help you. Tell me about a time when you advocated for a patient. What was the outcome? This is a very common question in a lot of residency and medical school interviews because we want to see, how would you advocate? How would you go that extra mile for your patient? Can you discuss a time when you took an active role in leading a team during a project? Again, this is looking at teamwork and are you a leader? Finally, how would you approach a situation if you found one of your colleagues was found to be doing something unethical? Or I guess in other cases, how would you deal with someone who was, found to be drinking but being on their job? So these are very, very common questions. Like I said, they're just really a teaser. There's a lot of interview prep out there. Again, I'm happy to help anyone who needs it afterwards. Feel free to reach out. I'll have my email address at the end. And then can meds. So that's essentially, if you were to Google, it shows all of um, the ways that we as physicians are supposed to be, working and responding to things. So can meds is the way that a lot of the interview prep questions are asked. So they cover bases on, are you a good collaborator? Do you have good teamwork skills, right? So look into it when you get a chance. I think you'll find a lot of information there. Now, I am going to just pause for a second here and ask, hopefully someone in the chat will tell me, or you can unmute yourself. Has anyone ever seen this before?
I
You have, great. And does anyone know what this exactly is?
I know what it is. Is it MBTI, the 16 personality types?
That's right. That's exactly what it is. So there are 16 different personality types. I don't know if anyone's done a personality test before. I've done one like 7 or 8 times, different ones. But the first one that I ever did was, I think, in my first year of university, and it was an eye opener. And what it really helped me understand was what kind of learning do I, best learn from, or how do I present? So, does anyone know what kind of personality type they are?
I'm also an INFJ.
Awesome, awesome. That's great. So let's take a look at something here. ISFP, that's amazing. INFP, a lot of INFPs, that's great. Um, so I'll kind of skim over this a little bit, but these are the different key types, and then we get 16 combinations from here. And not everyone obviously fits in the same um, category or basket, right? Like we're all different. It's just a way of how we learn, how we present, and how we are. So not everyone's going to be a leader, not everyone's going to be a follower, but it really helps us understand how we think and perceive things. So again, these are all of the personality types, the most common ones. So if we were to take 100 people in medicine or a healthcare field, these are the 6 most common types. Now, I know some of the ones that we just talked about aren't here, but that doesn't mean that it is not prevalent. They are. But usually what happens is, so for example, I've always been an ESTJ, but I think through various experiences, there's some situations where I'm more of an ISTJ, or I'm an INTP, which isn't even circled here, but it does change, but it's really cool to know which category you fall in. So if you haven't done one, definitely do it. It's really fun. So to kind of talk about family medicine before we get into some of these cases I have, there are so many opportunities in this field. As you can see here, these are just some fellowships you can do. So fellowships essentially come after you're done your primary residency training. You can always scope up, scope down. You can focus in on something or keep it very broad and general community medicine. It's really whatever you want to make out of it, but there's endless possibilities. So let's start with a case. I know it's not going to be the most typical way because we're not able to really see the patient here, but I will try and go through it as systematically as possible. If anyone wants to unmute and talk about things, please do. If you guys want to use the chat feature, please do that. So we have Alice Jackson. She's a 25-year-old female who presents to the office with abdominal pain. How do you think you would start to approach this patient? What are some things you'd want to know about Alice? And do you have any differentials on your mind? So I'll take a minute for you guys to just think about it, either put it in the chat or just yell it out. Tell me what are some things that you guys are thinking about. Anybody? When did the pain start? Okay. What other questions would you guys like to know about her? Okay, so let's go over this. So the way we start with a patient is usually with an HPI or history of presenting illness. So when did the pain start is an excellent question. Check for inflammation. Yep, okay, definitely. And so we'll go over all of these. These are great questions. So the first thing we always want to do is history of presenting illness, right? So all the who, what, when, where, how, and then the review of systems with it. Pam hugs Boss, it's a mnemonic. And I'm going to say this maybe several times, but mnemonics are your best friend through medical school. And these kinds of mnemonics, there are many. I can always share with you guys if you want them, but they really help you kind of have a toolkit in the back of your mind and quickly access it whenever you need. And then the differentials. Okay, someone said, do you experience any other symptoms with the abdominal pain and new occurrence? Excellent, excellent questions. So PQRST, that's our HPI mnemonic or history of presenting illness. So anytime you have any pain, whether that is chest pain, abdominal pain, back pain, even for headache, I love these questions. Everyone, I would say universally, will ask all of these questions in no particular order, but it really tells you about that symptom. So someone had said, when did it start, right? Or any other symptoms. So yeah, so for this patient, Miss Jackson, 25-year-old with abdominal pain, what makes it better? What kind of pain is it? Is it sharp? Is it dull? Is it burning? Where is it exactly? And does it radiate or travel anywhere? On a scale of 1 to 10, with 10 being the worst pain you've ever experienced, how would you rate your pain? When did it start? How long does it last? Has it ever happened before? So these are great questions for you to kind of ask the patient and for them to answer, and then hopefully for you to kind of narrow in on your differential diagnosis. And then we get into review of systems. So someone asked, is the abdominal pain a new occurrence? So that is going to be part of your review of systems, and also if you've experienced any other symptoms. So we'll get to that in just a moment. But so for our patient, 25-year-old, she says she has sharp pain on the right lower side, radiating to the back and to the groin sometimes. She says it comes and goes over the last few days. It's about a 10 on 10, lasting a few hours every time. Advil helps her sometimes, and it has happened before where she's had to go to the hospital to get IV medication. So this is the PAM hug spot. This is essentially our review of systems and past medical history. So anytime you are seeing a patient as a medical student, and oftentimes as a resident, and oftentimes as a practicing physician, you're going to do something called a history and physical. So patient comes in, they have their chief complaint, abdominal pain. You go into your HPI, which is your PQRST, get everything you want to know about the abdominal pain, their review of systems, and then you do essentially a head-to-toe assessment with a physical exam and other questions. And hopefully with the history alone, you will be able to figure out what is probably going on, and then you proceed with the examination. So here, for example, another great mnemonic, Pam hugs Boss. We need to know her past medical history. Does she have any allergies? Are there any medications she's taking actively? Has she been hospitalized? Are there any urinary symptoms, gastrointestinal symptoms? Has she had any changes in her sleep with this? Is there any family history of this? What's her obstetrics history? What's her social history? And what's her sexual history? So not everything's going to be pertinent for every case, but for this patient, she has no significant past medical history, no history of renal stones, no known drug allergies, no medications she's on, no hospitalizations. She has no burning when she urinates. She has some nausea and vomiting, but no constipation or diarrhea. Her sleep is not affected by this. She has no significant family history. She did have her period about 2 weeks ago, which was regular, no vaginal discharge. She's never been pregnant. She is a non-smoker. She does consume alcohol occasionally, occasional marijuana use, not sexually active, and no history of STDs. So this is our patient. This is 25-year-old Alice. Pain on the right lower side, right where this picture is showing us. Does anyone have any differentials before we get into the physical exam? Any diagnosis you guys think that could be going on? Okay, so let's go over some of the differentials here. So with right lower quadrant pain, which is what this patient has, we might be thinking about appendicitis, right? Inflamed appendix. Could be thinking about an ovarian cyst. She's a female. We could be thinking about an inguinal hernia or hernia in general. We could be thinking of things like IBD or IBS, or inflammatory bowel disease or inflammatory bowel syndrome. Or we could be thinking of ovarian torsion, so when the ovary kind of torts or turns on itself. Now, this is her physical examination. So our 25-year-old patient, we always start with some vital signs for every patient. Doesn't matter if they're there for abdominal pain, headache, if they're there just for a rash, always do their vital signs. That will tell you a lot about the patient, right? So if they have a fever, there's some sort of sepsis or some sort of infection processes going on, right? So in this patient, blood pressure, heart rate, respiratory rate, temperature, and pulse ox are all normal. She has no masses, no skin changes on inspection. In terms of auscultation, there's normal bowel sounds in all 4 quadrants or all over the abdomen. She does have tenderness to palpation in the right lower side where she was experiencing the pain. Negative obturator and psoas sign. Does anyone know what obturator or psoas sign is? No. Okay. So the obturator and psoas sign are very particular signs when it comes to checking for appendicitis. Barney's point and negative Rothsing sign are also for appendicitis. And she's had normal percussion in all quadrants. And she has negative chandelier sign, which is checking for cervical motion tenderness. So the way you check that test is you just kind of tap at the back of the person's area of the kidneys. And if they were to kind of jump up, that would be positive cervical motion tenderness. And we would think more things like pelvic inflammatory disease. And then she also had a negative urine analysis. So with this patient, our 25-year-old, we had these kind of differentials. I'm sure there are a lot more, but these were like the top 5 that I would think of. After going over some of this history and physical, does anyone have any idea on what we think she might have had or is having? You can feel free to write in the chat. I would love to just get some input on anything. There's no wrong answer. Appendicitis, okay. Anyone else? Okay. All right, appendicitis. All right, so let's talk about it. So if we go back, let me see. So over here, we talked about negative obturator, negative psoas, negative Rothsings, negative Bernese. Usually it wouldn't be appendicitis, but that is the first thing that we think of. So not appendicitis because those things would be more prominent. Patient might also have a fever, and usually with appendicitis, pain starts in the umbilicus area near the belly button, and then it progresses to the right side. I also don't think this is IBS or IBD because the patient doesn't have a fever, she doesn't have constipation or diarrhea. Definitely don't think it's an inguinal hernia because we didn't feel any masses on the physical examination. So what are our options? It could be ovarian cyst or an ovarian torsion. Now, this is a little bit tricky, and my intention was not to trick you guys, but usually with an ovarian cyst, so in females through the menstrual cycle, usually cysts are very common in the beginning, and then by the time you ovulate, they usually go away. And in this patient, if we recall, she had a normal period about 2 weeks ago. And so likely she's near ovulation, so she probably doesn't have an ovarian cyst. Likely it's an ovarian torsion. So ovarian torsion, nausea, vomiting, discomfort, sharp pain, right or left lower side, because we have ovaries on both, comes and goes, and usually you do need to be evaluated or go to the emergency if this is worsening. So we have a second case. So this is Anna Doe, 37-year-old female with worsening epigastric pain for the last 1 hour, presenting to your office. Again, what's the first step? What are some questions now that you guys kind of know? What are some things you think you'd want to ask her? And feel free to write in the chat. So we're going to go over our PQRST again for this one, right? So when did the pain start? What makes it better? Tell me about it. How long has it been there? What's the pain scale? And then again, the review of systems. So for her, for a 37-year-old female, mid-epigastric pain radiating to the back, sharp pain, says 9 out of 10. Nothing makes it better. She said eating and drinking make it a lot worse. This is very sudden onset and it's never happened before. That's concerning, right? In terms of her further history, she does have a history of gastritis. She has no allergies. She takes Tums as needed, no hospitalizations, no urinary or gastrointestinal concerns besides that epigastric pain. No sleep issues, no family history, normal menstrual cycle. She smokes 1 pack a week, no alcohol, no drugs, works as a bank manager, and she's in a monogamous relationship with only 1 partner. So what's our differential here? Does anyone have any ideas? Mid-epigastric pain, so that's pain right here, just below the sternum. While you guys think, here are some differentials. So for mid-epigastric pain, we think of gastritis, and we know she's had gastritis before. We think of ACS, or acute coronary syndrome, so something regarding the heart. Costochondritis, so that's usually pain within the muscles or the costral muscles of your ribs. Perforated ulcer, pancreatitis, or gallstone disease. So you think of everything that's in and around that mid-epigastric area. So for her, we have her physical examination here. Does anyone notice anything unusual in her physical examination? BP, okay. What else? So here, her blood pressure is actually normal. Her heart rate's kind of trending up. It's still normal, so 60 to 100 is about normal, but her heart rate is very, very high, right? That someone said respiration rate. Yes, so her respiration rate is higher than normal. We typically like to be around 16 to 20. 28 is quite high. She's also having a little bit of a temperature that's coming up, but her pulse oxygen is fine. Now, someone said gastritis or ACS because gas can reach the sternum if there's accumulation. It can also seem like ACS because gas is close to the heart. Absolutely. So that's a great point that's been brought up. So usually, anytime, especially individuals who have a history of gastritis, when there is some sort of gastric discomfort, we have to rule out anything related to the heart, right? Because although gastritis or reflux disease can be there, we certainly wouldn't want to miss an acute coronary syndrome or a heart attack at that point. So moving on from the vitals of this patient, when we look at her, She is in respiratory distress. She has no masses, no skin changes on inspection of the abdomen or chest. There's pain on palpation below the level of the sternum, so right where she was complaining of the pain, and there's air heard in the right upper quadrant. Do we normally hear air in the right upper quadrant, guys? What's in your right upper quadrant? Anybody? What organ would be there? So the heart lays more on the left side. So the heart is really right here. Your upper quadrant is your abdomen. So right in here, right below the chest on the right side is where your liver is, right? So when we look at this patient's x-ray, so the way we look at x-rays, so looking at the x-ray, we're really looking at on the left side of the screen is the patient's right. And on the right side of our screen is the patient's left, right? So we're looking directly at the patient. And we see this little bubble, if you guys can see, right where the lungs are, just below that abdominal cavity. So there's an air bubble or a gas bubble there, right? So when we have that, that is a medical emergency. And so with our differentials, it's not gastritis. We wouldn't see the air bubble. It's not acute coronary syndrome. The heart rate, although a little bit higher, was not really super high. The blood pressure was fine. What she really has is a perforated ulcer, right? She has a history of gastritis. With this sudden onset, it's really caused that ulcer to perforate, and now there's gas in that upper right side of her belly or abdomen. So that's a medical emergency, and we need to call surgical friends for help here. So those were some of the cases, just for some tips and careers, if I can leave some for you guys. I know there are a lot. These are just some things that I kind of picked up along the way. So gain experiences, as many as you can at every level possible. I did a lot of volunteering. I ended up doing co-op in high school with the hospitals and tried to work throughout the way of my career, just so I know that, you know, I'm happy with my choice, and you learn a lot of skills no matter what kind of work you do. Speak to community providers. I am personally very, very happy to help you guys whenever, wherever, however you need it. Feel free to reach out. Talk to other experts in the areas that you're interested in. Speak to a lot of your senior students and colleagues. Know that you're in this field for commitment for lifelong learning, because whether it's family medicine or, you know, surgery, internal medicine, you're always going to be learning, right? So medicine wasn't the same 20 years ago, and it probably won't be the same 20 years from now. So you will be learning all the time. Know your differentials in OSCEs. I think that's where you really learn a lot. So for every area, every chief complaint, right, know what are the different possibilities your patients could have, and that's really going to help you guide your management and treatment. Time management, I think all of us in healthcare field usually have. I think it just becomes ingrained in our minds as we go through all of these years of extensive training. So I'm not too worried about that. The one thing that I do want to let you guys know is please look into some, you know, financial tips and tricks. Definitely as a science student all the way for me, I didn't really pick up on the financial side of things. And I think no one ever really talks about financial planning when we're younger. And so if you have any experience, if you, you know, have any friends, family members, any advisors, just to know a little bit more about finances and things, that would really help you along the way as well. So I'm going to open up the chat and everything for questions. I'm open to a lot of questions. Whatever you guys want to know, I'm happy to help. So please let me know. And thank you. And then this is my contact information. I do monitor my email and Instagram all the time, so feel free to reach out any way you want. Why do I love women's health? So it's been something that I feel, and I don't want to say this in an improper manner, but I think as a woman myself, it's just something that I feel I go through a lot of things with my body as well and my health, and I've always wanted to know more. And really, as a practicing physician, I see a lot of, young females. So I'm working in Mississauga and Brampton right now, and I see a lot of young females from all different ethnicities who come to me because they feel comfortable talking to another female, right? And I think I've really started to understand women's health a little bit more, and it's not just medically. I think even on a personal level, I can relate a bit better to with my patients, and I really enjoy doing that. Any favorite mnemonics? Um, yes, I do. I would make like weird um, stories and songs. I don't think I have them all written down somewhere. I can certainly share them with you later, but PQRST is definitely one of my most favorite just because it goes with so many things and with a lot of chief complaints. You can really use it and you'll never forget. Okay, sorry, let me just go up to some of these questions. What are your thoughts and experiences with physician burnout? Um, I think it's a real thing. So I've gone through a lot of burnout, as I think most residents do go through a lot of burnout. There were times in residency. So in residency, the way it worked, we had an eight resident per year program. So 3 years, we had 24 residents. And first year was insane. We spent almost 90% of our time on hospital rotations, going from internal to surgery to pediatrics to ICU, et cetera, et cetera. And by the time I came to third year, I felt I was burnt out. I was also doing chief residency that year. So I was managing all the other residents in the program. And there were times where I hadn't come home for like 130 hours straight. I was in the hospital. I remember I spent 92 hours in my third year in February, late February, where I spent 92 hours with one of my pregnant patients waiting for her to deliver. And so at the end of it, I felt what really brought me out of this burnout and things where I was missing like my family's, birthdays and milestones and weddings and friends' weddings and bachelorette parties. I feel like you get really close to your peers, you get close to your residency folks and colleagues. And I think collectively you need a venue or you need somewhere to vent to. And it really helped just talking to some of my friends at that time and making sure I would take at least, even if it's an hour a week to connect with some of my close friends back home in Canada or my family members. I think it was very important. But don't let burnout is a real thing. Don't let it get to you. Don't let it be a reason to not do something you love, but also don't let it pile up inside you. Make sure you talk to somebody. I feel like if we can all have one or two people that we can trust in and talk to someone, it's really going to help you guys. Do I have any advice for selecting a residency? Yeah, so I think it's really something, just go with something that you really want to do, go with your gut instinct. I think that we have a lot of ideas of what we want to do. So if we're in medical school or even earlier in undergrad, I think a lot of us kind of think that maybe we're going to go to internal medicine and we're going to do cardiology, right? Or we're going to do gastroenterology. I think those are great. And I used to be kind of stuck in the middle before between internal and family. But I think a lot of it, even though if you have some ideas of what you want to do, I think trying to approach it by doing multiple elective rotations in med school is a great way to really solidify if that's what you want to do, because you have to be happy with it, right? It's not something that you're going to do for 2 years and you're done. It's something that you're going to make a career out of. But I think the good thing right now is that no matter if you go into a very broad spectrum specialty like family or internal, or if you go into very subspecialties of gastroenterology or peds oncology or whatever that is, I think they're also fulfilling and you can always scale up or scale down. And I think that's the beauty of medicine, especially with so many changes that we're seeing, that I think just be happy with what you like. If you don't really like doing a lot of surgical procedures, don't go into a surgical residency program. If you like talking to people, don't go into radiology, right? If you don't like interacting with people, go into radiology. So I think you would really have to know what you really enjoy doing. What would you say to help out a student who is contemplating between different careers in the medical field? So it depends. Like, what do you mean medical field? Like, do you mean between like nursing and medicine or pharmacy? Could you elaborate a little bit more on there? I think that's from Leah. And the next one mentioned doing co-op. I thought about doing it so I could also do time at the hospital. Yeah, I would say so. Co-op was actually one of the best things I did. I did co-op in both grade 11 and grade 12. And yes, with IB next year, it definitely is heavy in terms of your schoolwork and things like that. But co-op would be a whole, course worth where you would be able to go to a hospital or urgent care or wherever you'd like to go to get that experience. If you're not able to do co-op and you feel like it's not the right thing for you, and I would really judge probably in 10th or grade 11 even, if you feel like that's not working out or it's too much to handle, then definitely look for opportunities to just shadow someone, right? And to see if you like that field. For any of you guys, if you're ever looking to shadow or you want to do, a day here and there and see what it's like, feel free to reach out to me. I'll definitely try and make it happen for you guys and help you wherever I can, if you're in the area, of course. But if you can get any clinical experience early on, like co-op, I would recommend it. Medical school residency can be stressful. What advice do I have about mental health? What do you enjoy about medical students? What's the most interesting thing about them? Do you have any specific advice for pre-med? Okay, a lot of great questions. So let me tackle them one at a time. So mental health, absolutely. And I think, May is Mental Health Awareness Month. So I think more and more people are being aware of how serious mental health is, and it's not a stigma. And we really need to treat it like we treat anything else, like blood pressure or heart disease or diabetes. And so taking care of mental health is so important now. Like, definitely try and get a good night's rest. I feel like, and I feel like we are all in the medical field the worst critics of ourselves, right? Like, we never take time away for ourselves. And we've all heard that, doctors make the worst patients. And it's true, right? We're there just helping everyone nonstop, and we never really sit down and help ourselves. So I would say make sure you check in with yourself, right? Your body will tell you a lot about how you're feeling. If you're not feeling well, you will feel the burnout. And, at that point, just stop. Taking even a 20-minute break, whether it's, listening to your favorite music or going outside, meditating, exercising, cooking, whatever it is you enjoy doing, please make time, whether it's even 10 minutes a day. I think it's really going to help you refresh your mind and, if anything, succeed a little bit better. What do I enjoy about medical students? I love medical students. I feel like there is so much to learn, and I wish I really had the opportunity, or I wish I knew better when I was in medical school to be able to find these opportunities to shadow some of the community providers. But my medical students, I feel like, because I'm also not too far out from residency or from training, to an extent, I feel like I can relate to them a bit better. So I love the ideas they bring. I really enjoy when the students are with me because it makes me be on top of my toes and know everything and, be ahead of my game and be able to answer questions for them. I think they're just so innovative. They teach me a lot more than I teach them because they're learning some new things, or we'll kind of tackle some interesting scenarios together. And I love that. Advice for pre-meds and medical students. Yeah, enjoy your time. I feel like at pre-med, I feel like you should probably focus more on, do you really want to go into medical school or not, right? I think that's the biggest question we all have, because we all want to go in the medical field, but we can't figure out which one it is. So pre-meds, definitely remember to know where you want to be, but definitely enjoy your time because undergrad years don't come back. And I think I had a great time and would I go back and do it again? Absolutely. Would I do things differently? Absolutely. I would probably take more time out for myself again because I would always be behind books and reading and things like that. For medical students, enjoy. I think it was after residency, I think medical school was probably the best time of my life. I wish I had some pictures here I could show you guys, but um, it was the time when I really got to understand myself. And I think a lot of it is because I was away from home, I was in a different country, I was surrounded by other med students who are also away from their home and families. And so when we were there, especially in my third and fourth year, I've never lived in Manhattan before that. And so for me, being in Manhattan made me fall in love with New York City, made me love travel and, go places and just get experiences. I think with medical school, yes, you're doing all your rotations, but at the end of the day, you don't have a lot of responsibility, right? Like you're seeing real patients, you're managing them, but you're co-managing them with your residents. So I think it is a great time to really know yourself and go crazy, explore, understand what you like, what you don't like. Because at the end of the day, it's those experiences that you're going to gain will really shape your residency. Earlier in the virtual shadowing, discuss medical apps. Do you have any favorite apps out of the ones? Yes, I do. And then the next question was about study tips. So let's go back to that one actually. Um, so for medical apps, my favorite ones is definitely you up to date. It is something that if and when you are in medical school or residency, so that's the second one here, you will definitely be able to get access to. It is a paid app, so you do need to pay for a subscription, but it has up to date information as of like this month for certain diseases. It has all the medications out there, the dosing, the diseases, how to manage, what diagnostic tests you need, differentials. That was definitely and still is my favorite. It's on my phone, it's on my home screen. I use it almost weekly, if not more often. USPSTF and CTF-PHC. Those are the two clinical guidelines. So the first one is for United States and the last one on the left side is for Canada. So it's great for examinations. So a lot of our examinations were, and even for you guys, they will be related to clinical guidelines and when do we screen what, right? So screening for pap smears, for example, for females, we start at age 21 and it's done every 3 years. For mammograms, we start at age 50 or earlier if there's, positive family history. And for colon cancer as well, we start at 50, and I believe they've recently changed it to 45. So it's a great tool to know, especially if you're in family medicine for preventative health. Um, the MD Calc and the pre-op assessment were great ones that I used throughout my hospital days and hospital rotations because you'd be clearing your patient for certain procedures and surgeries, and MD Calc was a great way to kind of get some diagnostic tools to see what kind of risk some of your patients are in depending on the disease. So I love all of them. I'm free to have a one-on-one with anybody. You guys have my email. Feel free to email me, and I can definitely have a call with you guys too if you need. In terms of study materials, yes. So there were a lot of books out there, right? I did so for the Canadian boards. Mostly everyone uses the Toronto Notes. It's a very thick book that has everything in it, probably like size 7 font. But really, I studied alongside USMLEs as well, and so the first aid for USMLE Step 1 and Step 2 has everything you need to know for examination purposes. And so when it came to exams, I studied through those, including Master the Boards. for just general studying and tips and tricks, I'm a mnemonic person. I do a lot of mnemonics. I will definitely email them to you guys if you want. Shoot me an email and I'll get back to you. But really, it was just having up to date with me and reading about everything all the time. Any new case I would see, I would write it down in my little book and I would kind of read about it in the same day. And I would make some notes on certain medications. It's the way you learn, really. I'm more of a visual learner. I know a lot of people are more audio and visual, so you can always look up YouTube videos these days. There's so much resources out there. So I'd say these were probably, the holy grail for me. But definitely there are more resources. If there's certain specific study type or ways that you guys study, I'm happy to go over that with you as well on what might be the best way for you to study depending on your learning style. Any other questions? I hope I covered everything here, and I think we're pretty much at time. But yeah, I'm happy to go over anything. I'll leave my email address here again for you guys, so you can get it. And feel free to just email me or get in touch. Thank you guys. Have a good one. Bye now.
Bye, everyone. Thank you so much for coming. I hope you guys enjoyed it. And if you guys have any questions or concerns, you can feel free to contact us through Instagram, Slack, and email. We'll be happy to help. Bye, everyone.